Good afternoon. I'm Kelly Blevins. I am an orthopedic surgeon with the Department of Orthopedic Surgery at UT Medical School in Houston with UT physicians, and I've been asked to speak on ankle injuries by the Memorial Hermann Ironman Sports Medicine Institute. And so today we're going to have a little talk about some common ankle injuries, how to make the diagnosis, treatment options, and the recovery process of how that goes with treating those injuries. We're not going to cover everything that can be possibly covered in this topic, but I've selected a few that are the common things that we see and are maybe more interesting to discuss today, and we'll go through them kind of one by one. We will be having a question and answer session towards the end of the talk, so if you have questions, just submit them, and we will work towards that at the end and discuss those issues. These are basically the five conditions that we will be discussing today. We'll start out talking about ankle fractures, which are very common and come in all types. See this in all different types of patients as well, athletes to just standard people in our community. So it's always helpful to know how to treat those. We'll talk about Achilles tendon ruptures, which also have an interesting treatment and some options that are worth discussing. We're going to talk about lateral ligament instability, which is typically more of a chronic problem for folks, but you have an injury pattern that leads them to that situation. And then we'll talk about osteochondral injuries, which basically means an injury to the bone and cartilage that come in two different versions, one being traumatic and another one being a non-traumatic version that is a congenital abnormality. And then lastly, we'll discuss peroneal tendon tears, which are also common and present sometimes late, but are related to an injury itself. So to start with, ankle fractures, like I said, are very standard for orthopedic management and injuries that we see. All of the history and problem solving and such we will talk about in all these different conditions. So that ankle fractures, specifically, what we want to know about is the type of a mechanism of injury and how people sustain such injuries. So hearing that from the patient as far as what they were doing when they sustained the injury is really important, and listening to what they tell you because it helps us make decisions on what the condition is and how to treat it. Obviously, the type of pain they have and where its location is significant. And then also related complaints. Sometimes patients will have areas of the skin will be disrupted. There'll be a nerve difficulty or something in the sense of having some numbness or tingling or deficits on examination that are important. But often this is all started by the patient giving collecting the proper information in the history from the patient. Examination is important, and on examination, and this is true for all our conditions we're discussing today, look at inspection, inspecting the skin, making sure it's intact, looking for swelling, bruising, obvious deformity, alignment. All those things are significant and important. Do a good examination on palpation on what areas are tender and painful, knowing those are the areas of concern typically and are involved in the injury pattern. Examining the patient's range of motion, both active and passively, and can they even participate with that part of the examination? Sometimes that's difficult and indicates a certain level of involved injury. Then we look at the stability around the joint, around the ankle and the foot, and that's important for knowing the pattern of injury in the degree of involvement. And they also look at the vascular status of the extremity, swelling, neurologic deficits as far as either muscle control or as well as sensation and other factors. Things that are helpful diagnostically for ankle fractures. Most commonly, plain x-rays are very helpful. And we can usually get a fairly good idea of the fracture pattern and what's necessary for treatment based on those findings on those studies. Often a CT scan can be helpful if it's a complex pattern of injury that needs more of a three-dimensional evaluation to make some decisions on proper planning, usually for a surgical management. In this x-ray shown here, this is kind of a typical fracture pattern of an injury that actually is in fairly good alignment, but having two planes of x-ray are very helpful to understand exactly the definition of the fracture pattern. Common fractures really are divided into a classification system brought on in the early 70s and in 1972. It's called the Weber classification, and it's based on location. And so very commonly we'll describe and plan our treatment based on this classification system. A being a lower fracture of the fibula. I'll try to point to that here. And this often comes with more of an inversion type injury where the foot very quickly goes inward, breaking off the tip here. And then on the Weber B fracture pattern is more of an oblique fracture pattern that kind of comes through the joint and often involves a medial malleolar fracture as well on the inside of the ankle. And if both of these bones are involved, very commonly it'll be unstable. And then the Weber C pattern is a higher fracture up here with usually more comminution and smaller fragments. And it often, energy goes down through this area here and through the joint to cause the injury. And often this ligament here, called the syndesmosis, is disrupted as well. There's another classification system that's a little more complicated, developed in the 1940s. And really is defined on basically the position and the mechanism of how these things happen. It's a little more complicated as far as understanding, but what it does help us with is understanding what position to place the ankle in to provide stability. And this is more in line with what we used to do when we would have long leg casting as the option for displaced fractures to recreate the deformity and then do a reversal of that. That's just not done commonly now, so we really do stick with the Weber classification for simplicity. A conservative treatment for ankle fractures comes in really two versions. Bracing really doesn't have much of an acute phase as a management option, but casting is not uncommon. And what we're looking for is really a fracture pattern that is non-displaced, meaning the bone is in the proper position, and all the things that we can look at as landmarks are in the right position as well to allow us to know that management and that fracture and that bone will heal in the proper position. One of the issues we often see, and this is an example looking at this on A here, what we're looking at is the joint congruency of how the talus lines up underneath the tibia. And there is a small fracture here, kind of a Weber B fracture pattern here on the fibula, and that the joint spacing is normal, and it's congruent all throughout here and medially. And if you look on B, it doesn't look like much of a fracture here as well, but you can see the definite difference here where there's a gapping medially, and this is not necessarily going to do well. The ankle joint is very congruent, so any displacement, even 2-3 millimeters, can be significant and cause for premature wear of the ankle and not a good functional outcome. So sometimes casting in that case may look like a good idea, but actually is not, and it needs more of an involved management being operative. Bracing has more of a secondary function. Once the casting is completed, there's enough healing. You can let people be more weight-bearing with some additional protection, but work on more of the functional outcome part. Operative management for ankle fractures usually includes what we call, or in term, a open reduction and internal fixation. And that means basically open being making an incision, a reduction referring to the realignment of the bone to the proper position, and then internal fixation, meaning placing hardware, typically plates and screws to maintain the position of the bone to allow it to heal in the proper position. Sometimes we can do what's called a limited open reduction, which involves smaller incisions and using percutaneous fixation, which is helpful if possible. We can also use the x-ray machine at surgery to help us do some of these things for us position and understanding that. And there's also a role for even closed reduction, which is meaning no incisions are made and can just position the bone to our proper position and then do the fixation. Because we typically have to do the fixation, the incisions are necessary to put the hardware in. So I'm going to just give an example here. This is actually a 15-year-old quarterback that I treated last week, actually, who was pivoting and cutting and actually got his cleats caught in the turf and had a significant thrusting mechanism with a rotation as well as an inversion, and has significant injury to his ankle. If you can look here on this front view, he's got a significant comminuted fracture and multiple fragments of his fibula here, and then this unusual fracture pattern involving his distal tibia. His growth plate on his tibia, if you look over here on the side view, is still open in the front portion of it. However, towards the back in here it is closed. And so what's happened is the energy is dissipated through the open growth plate region, which is slightly unstable just given its nature. And then because now this is all fused back here, it just tears the bone in a different location. So he underwent a closed reduction in the emergency center to get the proper gross alignment of his fracture, and then I was seen in the office and scheduled for surgery to fix the bone in the proper position given its displacement. And here's an example of what we did. So if you can look here on this front view, we've placed 3 screws front to back in kind of a stepping fashion, following the fracture pattern to get the proper location to hold the position. And then you can see the lateral view here where the screws actually go through the tibia and have reduced this nicely onto the growth plate, so there's no damage potentially there. And then we put a plate and screws on the outside bone, the fibula, here to hold the position until it will properly heal in that location. His distal fibular, growth plate here was actually nearly fused, and his tibia is working on that as well. So there's not really much of a risk of a growth disturbance at his age, but a fairly unusual pattern at his age. Usually these are more closer to being fused and not so much a concern. So recovery on ankle fractures varies, but typically, especially after surgical management, there's a non-weight-bearing portion where we're allowing the bone to heal in the proper alignment until we stress it, and that's often 3 to 4 weeks based on the pattern and the amount of healing judged at that time with x-rays. And there's weight-bearing with some protection, and typically in a fracture boot, and the initiation of some simple exercises for range of motion. And then there usually is a fairly involved process of physical therapy in the sense that it's done routinely for about 6 weeks, so sometimes overlapping the protection period with walking in the boot and doing some physical therapy, and working on functional recovery. The patients typically are much better and can walk around in the fracture boot for some time, feeling fairly normal, but are not ready to return to play for several months. And so typically, for this gentleman I was describing and we had surgery on last week, I mean, he will be hopefully at a healed bony stage in about 8 weeks, but probably not ready for a return to play for another 2 to 4 weeks after that. So next we'll talk about Achilles tendon ruptures. Achilles tendon ruptures commonly are found in, very commonly are men actually as patients. And the age group is usually, demographically, is a 35 to a 55-year-old gentleman. Here I'm showing Kobe Bryant tore his ACL, his Achilles tendon during the last game of the season this year. And just when he was, cut into the basket and basically sustained this injury. And the way it happens is more of what we call an eccentric loading pattern. It's the muscle is, for the calf muscles are firing and contracting, but at the same time there's an exertional force causing it to slowly elongate. And that is very stressful on that muscle complex and often causes it to actually fail under that stress. And it just breaks. And so what happens commonly in these, people will think that someone hit them with a bat at the back of the leg or were shot or something significant. And he actually accused Harrison Barnes of kicking him in the calf immediately after that. He asked him, "Why did you kick me?" And so it's a very common occurrence with patients the way it feels. On examination, these folks have usually a palpable defect. You can feel the actual spot where the Achilles tendon ruptures. And then a very common test that's very helpful is what's called the Thompson's test. And in this, you would take the calf and actually squeeze the calf muscle and passively watch the foot to see if there's any plantar flexion. So down here on the bottom, in a normal intact Achilles, the toes will go down, and that's a negative Thompson's test. Positive one, as depicted in the top view, there's no plantar flexion, because what happens is there's a disruption of that connective tissue posteriorly that holds that position that would allow for the tenodesis effect, or the pulling of that tissue, even just with passive stretch. That in itself is usually enough to make the diagnosis. It's very helpful and really about all you need. X-rays sometimes are necessary to make sure that you don't have an avulsion fracture of the tip of the Achilles. The tuberosity of the calcaneus where it inserts. But MRIs, you can get them as shown here, where you can see the disruption in that the black tissue and the white area where all the swelling is, but really not particularly helpful or necessary in most cases. The physical examination is enough. Conservative treatment has its pros and cons. There's a lot of debate in orthopedics on which to do. There are some who are definitely in the camp of conservative management and have some reasonable results. There are others that think that the surgical management is a better option. I am that. I found that the results are more predictable with the surgical treatment. But conservative management, the pros would be that there's no surgery necessary in that circumstance. And what you do with these folks is typically it's a protective routine of serial casting, bringing the foot from a plantar flexed kind of tiptoe position in a cast, and then working it down as it heals over several weeks and doing serial casting. That is good in the sense that it's not surgical. The problems are, and this is definitely shown in the literature, is there's an increased risk of weakness, that you just don't get the proper musculotendinous tension on the tissue to reproduce what we would love to do as far as jumping and running and activity. So they definitely notice some weakness with push-off. There's also the risk of re-rupture, because scar tissue is interposed in the area where the tendon would be present, and that tissue is just not as durable and is a risk for re-rupture in comparison to the normal connective tissue. So with operative management, the pros are, as I mentioned, are a more predictable outcome. Typically, you can almost put these people on the timeline of once they're fixed, based on the timing and length of time from the type of surgery they've had as far as the pattern, and then also the physical therapy that's necessary, where these people are going to be in several months. So it's a little more predictable. The repair itself, being that we use a non-absorbable suture to hold the position and act kind of as a lattice work for the tissue to heal, is helpful. We can also get the proper tension to match the opposite side, which is also helpful. And obviously, because you have some non-absorbable suture present, the risk of re-rupture is not as great. And the only con here would be that there is a surgery that's necessary. One thing we have done for the surgical management that has become helpful is a technique which is termed a mini open technique, and this is shown here, where basically an incision is made right at the level of the rupture, and you identify both ends of the tendinous portion on each side of the incision, and you can actually pass the suture through this area and then out these smaller incisions made here, and allow the suture to be brought out through this incision, back through the tissue, out the other incision, back through the tissue, and do it on both sides. And you can actually tie the suture within the substance of the tear to get the proper tensioning and allow it to heal. And that, as opposed to doing a incision covering this whole area, has become very popular recently, and really speeds recovery. Recovery in itself is typically an initial non-weight-bearing period of allowing some of the healing to happen before you're stressing it. And we follow this by a protective weight-bearing period of using a fracture boot typically, depending on the type of injury that there is. And then the rehab program usually starts with basically some range of motion exercises, but really not being stressful to testing the repair for typically the first 6 weeks. Then we get people back to doing more advanced activities. But typically we expect that running and jumping as an activity are difficult to accomplish safely and effectively for about 4 to 6 months. And they expect that, Kobe Bryant would be back typically about 6 months, maybe up to, 3/4 speed there. All right, so now lateral ligament injuries and instability. Definitely we see this. Most people who develop a lateral ligament instability pattern have had a history of recurrent lateral ankle sprains. And these are common. I mean, when people have these, they very commonly would just have an inversion mechanism, as shown in this first picture. And what happens is there's damage typically to this anterior talofibular ligament, which is also very weak and kind of confluent with the capsule. So it actually tears very easily with just kind of any type of twisting motion. And that would indicate more of a grade 1 injury where that's involved. A grade 2 sprain involves usually both of the ligaments, the anterior talofibular ligament as well as the calcaneofibular ligament, which really prevents this significant heel inversion. When both are completely disrupted, it's more of what we call a term of grade 3 injury. And so most people who develop some instability pattern, it happens secondary to a significant injury at least at one time, and sometimes a delayed treatment or no significant treatment for the ankle sprain initially, and then they have a recurrence of this pattern, and it just continues to be an ongoing issue. And it gets worse every time. And so they basically develop a true instability on examination. And the way we test for that are really 2 tests. We test this showing a talar tilt. And in this example, you can see in the x-ray, that this angle measured here at 20 degrees is significant. Your ankle should not open up like this, the ankle joint. It should be more like this other picture of about 4 degrees. That's kind of normal opening for an ankle. But when that happens to the 20-degree level, this person has basically no stability to their ankle provided by the calcaneofibular ligament. And usually in that case, that's a significant instability pattern. There's also the anterior drawer test where you actually can take the foot relative to the tibia and the shin bone and move it back and forth, and you can really tell how much excursion their foot has underneath their shin bone, which it should be, have a good endpoint, and these folks don't have one. So imaging can be helpful. The examination is actually more critical typically for making the diagnosis and then the history. But often these people can develop peroneal tendon injuries as well with a recurrent pattern because of the location posteriorly there in the outside of the ankle. And also sometimes imaging is helpful for planning the surgery. If you think that they may have some of these other injuries or things to identify, you may want to know that before going to the surgical management. Conservative management has some limited options. These folks all do improve with physical therapy to some degree and then bracing. However, the problem is it doesn't necessarily solve their problem. And these folks still are left with some degree of instability that makes it difficult to perform cutting activities as far as sports. The physical therapy really focuses on proprioception and balance as well as strengthening the peroneal tendons, which are the secondary stabilizers of the ankle and helpful in that sense. Operative management, in my hands, I typically do a combination of things. So first we will do an arthroscopic debridement of the ankle joint for scar tissue. And this scar tissue develops secondary to the instability, that basically there's this extra motion within the joint and it causes stress on the adjacent tissues and causes them to thicken. And that in itself is painful in some of these patients. Then they don't really understand why, but that it's often the case. And then doing a true direct repair of the ligaments of concern, being the calcaneofibular ligament as well as the anterior tibiofibular ligament, anterior talofibular ligament. We do that through an anatomic pattern of reconstruction. There are many methods described, and most of the non-anatomic tightening procedures have failed and fallen out of favor. Here's an example of a young college girl that presented with instability and had failed all conservative management. She had done therapy, she had done bracing, and still was having recurrent issues. And this is her ankle at arthroscopy. And if you look at this first picture, here is an example of the significant scar tissue that forms within the joint. This is my probe pulling on this tissue. And this is her outside bone, the fibula. This is the dome of her talus, or foot bone. And this is the tibia plafond, the shin bone. And those kind of make up the lateral wall, the floor, and the ceiling. And at this level, this is what we call the syndesmosis. Up in here is a ligament that helps maintain the stability between these two bones. And it gets overworked secondary to this lack of the other ligaments doing their functional job. And so often these patients have this big wad of scarring that's stuck in their ankle joint, and it's uncomfortable. And here it is afterwards, where after we've used a shaver to debride this and remove that scar tissue. And this is what we do initially, and very commonly what we find as the arthroscopy management, and then moving on to the ligament reconstruction. So the ligament reconstruction is done in several ways. Typically there's some version of repairing these actual ligaments. Here's shown where they actually are just sewn together in kind of a, what happens, they're elongated typically in heal, but in a pattern that basically is incompetent. So what we do is we can imbricate and cross them and actually use suture material to repair them. And that often works if the tissue is present. Very commonly there's a cup of tissue all in here that can be used that is kind of redundant, that you can imbricate and use, and it's more than just the actual ligaments as shown here. Often what we do in addition to doing this repair is we do this modified retinacular imbrication and advancement, and this is the tissue that keeps the extensor tendons in place. And what you can do is you can reef it off of that tissue and advance it to the fibula here anteriorly, and that often helps to protect this repair from failing with this extra buttress effect. And in here shown using suture anchors and actually placing these sutures into the bone as an advancement, and that's done sometimes as well. These folks for the surgical management, I typically keep my patients non-weight bearing in a cast for 3 weeks, and that's to protect the repair and allow it to start healing. Then it's weight bearing is tolerated in a fracture boot with some simple range of motion exercises. And then usually about a week or so into that routine, I begin physical therapy and start working on some light exercises. But we really want to be careful, because the risk is that you can actually stretch out the repair, and that's the last thing we want. So working on stiffness with therapy is helpful, but going the opposite way is not. So we're going to be really careful with that. But typically we get them out of the boot at the 6-week mark and completing their physical therapy. And usually with some sort of protection, patients can return to athletic activities typically about the 3-month mark. Osteochondral injuries come in several different versions. One can be from trauma, so patients have some sort of injury pattern to their ankle that can cause damage to the cartilage surface and cause loose bodies, or even damage to the bone and the cartilage, knocking off a piece of this. And that's more common, obviously, in significant traumatic situations, and more obvious with the locking and the catching symptoms. Sometimes patients will present with a progressive pattern of symptoms that really doesn't indicate any kind of true trauma that initiated this. And those folks typically have what's called an osteochondritis dissecans lesion, or a congenital defect in a tissue that will cause it to eventually fail and then cause damage to the cartilage, and sometimes give those mechanical symptoms. Typically these folks have tenderness along their ankle joint anteriorly, depending on the side of the lesion. And typically these people have failed previous managements. They've been treated for a bad ankle sprain and just really never got better, had a fracture that was treated but never looked into the ankle joint and have some residual issues. Plain x-rays are very helpful sometimes at seeing this, but often you don't see anything. Shown here and circled and highlighted here is a small dome lesion here on the medial side of the ankle on the talus, and this is more typical of what we'd see radiographically. But what you can't appreciate is the cartilage cap that is on top of this bone is often involved as well, and that really can be delaminated and peeled back, and really is what the patients are complaining about. On the MRI here, which are very helpful for evaluating this, you can see here in the bone there is significant swelling in the bone, indicating an injury and irritation of the bone with stress to it, as well as the cystic formation of the defect in the bone and then the overlying cartilage. And actually, in this case, this one, it appears intact in this plane, but you can see some loss of that nice cartilage surface in this one, which may indicate that there's some fibrillation and actually a tear within that cartilage cap. So conservative management really involves a physical therapy sometimes, but the key is whether these patients have mechanical symptoms. And most of them, if you really think that they may have a osteochondral injury or damage, they do have mechanical symptoms. That's what they come in for. So you can monitor the symptoms and try the physical therapies if that's an option and see how they fare. But the high index of suspicion, is often what you need to be aware of, knowing that these people present typically after an initial treatment that has failed. So operative management is often necessary, and there's several ways to treat these. Very commonly, we do this arthroscopically, and you can do several things with that method. You can remove loose bodies if they're present, or if there's a portion of the cartilage that's peeled off. You can actually debride the lesion or the spot that's involved and take the cartilage flaps if there are some present. And these often do respond to a technique of drilling. And so what we actually do, you can remove the cartilage area that's frayed and unhealthy and delaminated from the bone, and then you can actually drill the underlying bone to stimulate healing. So the idea is if you can get into the subchondral bone with this technique and get bleeding to happen, a clot will form that will then promote the possibility of healing fiber cartilage over that zone of injury. And that may be enough to help with the symptoms and mitigate any progression of the lesion. Commonly in some of these that are the larger osteochondral injuries or osteochondritis dissecans lesions, the bone underneath, as shown in that MRI previously, is basically missing, or there's a cystic formation present. And those are difficult to treat with this technique because you have a missing tissue that's hard to stimulate for healing. So in these folks, if we've had a patient who's failed a drilling procedure, we often try that first because they seem to work. And then you sometimes come back and you have to do what we call an osteochondral grafting procedure. And these include several different versions. There's one where we can actually take bone and cartilage cap from another source and actually do kind of a plug technique of putting it in there. The problem with this technique, to get access to the dome of the talus, you basically have to do an osteotomy and cut the ankle bone to get to this zone. It is a very, what we consider kind of a destructive process just to even get access to this area to perform the surgery, and it's never been desirable. So more recently, we've developed some other techniques that allow for a cartilage procedure to be performed on these areas, and sometimes it's successful. And this is a technique called de novo. So I'm just depicting how we do this. So here's an ankle arthroscopy depiction where you have the camera looking in one portal, and then the other one you can actually look at the area that you're working on and through the portal pass instruments to remove potentially loose bodies or debride this little cartilage cap or damaged area. And here's an example of the de novo procedure I performed on a patient who had failed a drilling, and it may be hard to see here, but this first picture This is his ankle joint to the anterolateral aspect of his talar dome. And if you can see here, this kind of yellow-orange area is actually after I've debrided all of the cartilage edge to a stable base, and that's all exposed bone. So this is his lateral shoulder, as we would call it, that's exposed, and it was a fairly large size area of denuded bone where no cartilage was present and did not heal. So what we do is you take these, what are called, they're juvenile cartilage cells, and they're minced. And what they do is they're harvested, and can't really see it very well, but they are placed on this defect, and it's kind of, see these little white dots here actually indicate them. And when we do this, we use this fibrin glue to be more of a biologic glue to hold the position. And these actual cartilage, minced cartilage chiclets, as I call them, will actually grow and form fiber cartilage. And this last picture is showing how when the fibrin glue actually sets, it's almost like a candy-coated shell that is encasing the area and has these cartilage, minced cartilage cells present. And what should happen is this will actually grow hyaline cartilage over this area, and actually, oddly enough, works fairly well in some folks. So we've been doing that more recently and have had some good success. And this gentleman actually did extremely well with this after being kind of a big fella that if it works in this guy, it'll work just about in anyone. So that's a good thing. So recovery from this depends on what is done. So if you just do debridement only, arthroscopically, these folks very commonly, I'll keep them off it for a couple weeks to get their wounds to heal, but they begin range of motion exercises and then some physical therapy to gain back the normal proprioception and balance to improve. Debridement with drilling, these need to protect a little bit to allow that cartilage area or that area that's been drilled to have this blood clot form and then de-differentiate into possible cartilage forming cells. So you have to be careful with that. So the protection is important. So still initially get the wound to heal up and then begin weight bearing in a boot, but prevent a lot of shear force across that zone. And typically that gets them to the 6-week point and then completing physical therapy beyond that. This chondrocyte implantation techniques, and there's several of them, typically this requires letting this cartilage cap that you've created really take hold and do what it does, and it really is a non-weight bearing period for about 6 weeks. Motion is helpful early just to get some of the joint fluid moving to that's nutritious, but you've got to be careful also for the shear factor forces across this zone, so weight bearing is a problem. And then so beginning weight bearing and walking on this in a fracture boot is what we typically do at about the 4 to 6 week period, and then of course letting this completely heal. And often these folks, we don't know how this is going till about 3 months, but at that point most of the patients will tell you how it feels, and you have a pretty good idea whether this has been successful. And lastly, we talk about peroneal tendon tears. These are not uncommon and actually often present late because what happens is these patients have an inversion or an ankle sprain type mechanism and think they had a bad ankle sprain that just hasn't gotten better. And so what happens is they'll come in and say, you know, I can walk and I'm feeling better than I did, but if I do anything exertional, my ankle really hurts and it swells, and it's all towards the back on the outside of my ankle. And so what happens is these peroneal tendons within their sheath will become very irritated, and that's part of the problem. And then you can actually develop a tear. And people who have a tendency for subluxation of these tendons around this outside and lower fibular area often are predisposed to the tendons being injured with that type of mechanism. So on examination, these folks are tender in that area where the tendons course. Often they're swelling, and this is right behind the outside fibular bone where they course. So here shown in this picture, a depiction of the course of these tendons that run here behind the fibula being here. The peroneus brevis being deeper and against the bone is often the one that typically is torn because it gets most of the pressure against this lateral edge. And then the peroneus longus running with it as well in that same zone. And shown over here, you can actually see this person with dorsiflexion of their ankle. Their actual peroneal tendons are tending the skin as they bounce around this edge. And obviously, this person could present even with subluxating tendons, or sometimes even present with a tear after that being attritionally causing damage. So diagnostically, x-rays really aren't helpful given this is more of a soft tissue problem. So it's important to know that they don't have something else, but other than that, they don't necessarily help make this diagnosis. MRIs are very helpful because you can look at several things. You can look at the anatomy and the location of the tendons. Sometimes you can actually see the actual tear, but you can also identify if these people morphologically have an abnormal fibular groove, which would be more convex than concave. What you'd typically expect is these tendons sit nicely in this concave groove as they run and do their work, and they lose their mechanical advantage if someone has a convex posterior surface of the fibula. And commonly, a diagnostic test I do at times, if we're not sure, is sometimes you can actually inject lidocaine or numbing medicine within the tendon sheath, and patients will tell you, oh, all my ankle pain is gone, and you have a pretty high index of suspicion that that is actually where the pathology is, and the issue is within the tendons, or tendon sheath, so either be in the peroneus longus or brevis. Conservative management is not particularly helpful, and like I said, most of these folks present after having a previous injury, have had some other treatments, and it's just a smoldering issue that just won't get better. Physical therapy can be done, but often not when you know it's a tendon tear. So some of these folks will have some of these managements, but it's not typically the treatment because the actual tendon tear itself will not heal on its own. Its blood supply is not set up for that. So physically, we have to improve that with surgical management. Operative treatment involves exploring the peroneal tendon sheath and doing the indicated repairs based on what the findings are, and then often knowing whether or not these folks need a groove deepening procedure to help maintain the position and alignment of those tendons once they're repaired. So if you just simply repair the tendon and they've got anatomy that allows for the tendons to subluxate and come around the side, that's not going to help much. So you need to identify those folks. So here's an example of a peroneus brevis tendon tear. And you can see actually right at the tip where those forceps are holding the split in the tendon. And that's the type of tear that happens. It's a split of the tendon very commonly. So they function, but they have this irritation that's chronically there, and that gives people discomfort as well as swelling. So here's actually the fibula, edge of the fibula poking through here, which causes the attritional damage to this tendon. So what we commonly do, we will remove the inner surface of the tear and debride that for, as we say, viability, and then actually do a repair technique with suture that basically tubolizes the tendon. And that works, and that basically creates a rope structure that's not going to split and move between each other, the two slips rubbing against each other and causing irritation. So in those that need a groove deepening procedure, a neat slick technique that we're doing these days involves taking sequential reamers of a drill and actually placing it on the tip of the fibula. And what you can do is actually make a hole within a hollow within the canal. And you can do this sequentially, increasing in diameter to get an area that you can create a groove. And so what you'll do then is you'll take a bone tamp and actually tamp the posterior cortex here and basically block it in, and that actually will fall into that hollow that you've created and creates a nice groove for deepening. And actually it works really well and is minimally painful, which is excellent. All right, so recovery from these is typical for protecting the repair for the first 4 weeks in a cast, at least what I do. And then another 4 weeks maybe walking in the boot. The problem is if you start stressing the repair of the tendon too early with the strengthening exercises, you get into trouble, typically causing some symptoms and difficulty in figuring out what's going on. So typically I don't let them start their strengthening program until about 6 weeks. And then typically after they're showing improvements and incremental advancement, you can definitely allow them to return to athletics when things are looking pretty good, usually at the 3 to 4 month post-operative period. So typically with a lot of these injuries, we see, and definitely some points need to be made about what can you do for people who are at risk for injuries or just ankle problems in general. And so sometimes what we like to do, physical therapy is a big part of that. And it's really important to work on strengthening. And typically what that involves is strengthening the peroneal tendons to actually help stabilize the ankle. So that's a physical therapy program that we definitely promote, as well as there's some balance exercises to do for proprioception. And that is very helpful to gaining an understanding of where your foot is in space to know to reposition it based on positioning and doing cutting athletics. There is a role for bracing and taping, both to prevent injury depending on the activity, depending on how high risk it is. But also we prefer that these techniques be used as a secondary additive feature beyond the things that really do help, which would be more the strengthening and the proprioception programs. There's a role for them, but simply doing that alone is really not that helpful because they're still at risk for injury if you don't get that extra help by doing the proper exercises. All right, so that's basically it. I guess now we could do some questions here. All right, so here's a couple of questions. Yeah, so one of the questions here was asking about the rehab program regarding Achilles tendon ruptures. Yeah, in my slide, I didn't talk about exactly what we do. It is something that is a progressive program. So typically, we start with protection and non-weight bearing initially, let the repair heal. Then we start we get into a period where we're doing progressive weight bearing, which really includes bringing the heel down to a normal position, because initially we want this to be tight, and if you stretch these people early, they really get into trouble as far as losing some of their strength. So that's progressive. The comment about the running and jumping not for 6 months, I mean, that's just saying that it really is a long period of recovery, and these folks really need to work through a progressive program of stretching and then getting to the point where they're safe walking, and obviously then working up to the running and the jumping at the six month period. So it's a progressive period for a long time there. So one of the questions here is about a critical period for surgery. I'm not sure I know what particular surgery they're talking about. I mean, any of these conditions, sometimes if it's an older injury, which is common how people present, not knowing what the problem is, but it just kind of goes on and it has chronicity. I mean, there's definitely, it doesn't necessarily change the treatment sometimes. It can change it, but often people won't be affected or affect their outcome necessarily. So I think it's just when identified as a problem, it's something you look at and can definitely evaluate. Oh, I'm sorry, there's the rest of the question. Osteochondral, yeah, the osteochondral injuries, to that point, there probably is an ideal time to treat these if identified, but very commonly they're not identified acutely. So that's not uncommon, and I think most of our programs and treatment options are developed with that knowledge. So I think it's more of an understanding of the situation, and it may vary, but it doesn't mean you don't treat it or automatically expect that you missed an opportunity to do the right thing. Last question here. Yeah, so you know, there are obviously other common ankle injuries and problems, and one of this question is regarding Achilles tendonitis. And there are a couple of different versions of this that folks can get. There is more the chronic insertional tendonitis. There is retrocalcaneal bursitis, which is more of an irritation of the tissues around the actual insertional area and in front of the tendon. And then there's some people who develop what was called Achilles tendinosis, which basically indicates that the tendon itself is unhealthy and is at risk for damage. And so it's hard to sometimes figure these folks out and often get treated similarly. In reality, though, they respond very differently. Achilles tendonitis in itself is more of an inflammatory process that can be improved with some rest and protection. If it's ongoing and goes for a long period of time, sometimes these folks will develop a tendinosis where it becomes damaged and unhealthy and is more difficult to manage conservatively. The retrocalcaneal bursitis often can be treated just with a simple injection and some of the protection options conservatively as well. So it just varies as far as that's concerned. But it's important to kind of figure out what patients respond to sometimes, because that gives you a better indication. And then sometimes actually looking at different studies at different intervals of their management can be helpful as well. Okay. Okay, so last kind of secondary question to that last bit about the Achilles tendonitis. Yeah, so usually for protection, we were indicating that you use either some sort of elevation of the heel to prevent the extra stress of going down to that flat foot position that people do when not wearing shoes. In general, I can't say that taping is particularly helpful. Very commonly in anti-inflammatory medicine, orally may be helpful. And then sometimes, like I said, the injection in front of the tendon, not actually into the tendon itself, can be helpful based on the patient's symptoms. But the other option for protection would be a little more involved, which would be wearing a fracture boot to really shield the zone to let things settle down. And often that helps, and some people only need that for a few weeks at a time. So that varies, but that definitely is worth entertaining and really does stay in the conservative management for quite a while typically, because you can get most people better if the effort's made. Okay, well, I think that's pretty much the talk. Obviously here shown on the screen is information about our location and contact info. So if there are any additional questions or something to address or you need treatment, please feel free to contact us and we'd be happy to help you. Thanks.